Every person has a unique personality and thinking process, but most of them work in day-to-day life. What about those of us who have problems due to disease or injury? Coping with neurological disorders. The doctors are on call tonight. Funding for On Call is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call, starting its 11th year of opening doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, Regional Health, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
Hello, and welcome to On Call. Tonight our show is about our marvelous nervous system and what can go wrong. The nervous system is made up of the complex computer or brain and spinal cord we call the central nervous system, and all the neurons or nerves connected to the brain we call the peripheral nervous system. Just think of the complex activity that happens when someone leans against a hot stove. An urgent message is sent from the nervous tissue implanted in the skin of his hand back toward the spinal cord where, without much thinking, another message is immediately sent back to the muscles of the arm to move quickly. Once the hand is removed, the spinal cord gets the whole story up to the brain, and there his thinker has some time to assess how much damage was done, to make plans for reparative action if needed, to tell the legs to dance around the kitchen for a while and to express to the world a comment or two about how hot that stove is while casting aspersions on someone's character. But like my engineering friends like to say, the more complex a system, the more the opportunity for something to break. A review of the trouble that can happen with the nervous system virtually fills books. If we concentrated only on degenerative nerve diseases, there could be trouble with the memory, emotions, numbness, pain, balance, movement, talking, breathing, and even heart function. Causes for deterioration can include genetic issues, repeated trauma, alcoholism, tumors, strokes, viruses, and of course the most all-encompassing cause for degenerative neural disease, unknown. Here to help us understand the illnesses that encompass the nervous system is Dr. Lisa Viola, who attended medical school in New York. She did her residency at Albert Einstein College of Medicine, New York City, and practices neurology at Neurology Associates in Sioux Falls, and he even does some outreach in Brookings periodically in my hallway.
Yes, that's right.
Do you wonder about how to measure for dementia, or what we understand about Alzheimer's disease, or Parkinsons, or strokes, or chronic traumatic brain disorder? Does MS affect your family? Do you know why those names evade us as we get older, and is it normal? Tonight we would appreciate your questions about anything involving the nervous system. Call 1-888-376-6225. So let's talk about the central nervous system versus the peripheral nervous system, Lisa.
Okay. Well, thanks for having me here tonight, by the way, Rick.
My pleasure. Our pleasure.
And yeah, you know, we're going to talk about the nervous system tonight, and the nervous system is split into two main categories. There's the central and the peripheral. So we're fortunate enough to have a model right here, and the central nervous system consists of the brain and the spinal cord. So the brain here, and then the spinal cord running down your back. The peripheral nervous system is the system where the nerves that exit the spinal cord and course throughout your body, and then the muscles which they lead to. So what we're going to focus on tonight is predominantly the central nervous system, disorders of the brain and the spinal cord.
All right. Tell me a little bit about why you went into neurology, Lisa. What drew you into that direction?
Well, I kept an open mind during medical school, and I just wasn't sure exactly where I wanted to go. But I think I really enjoyed the anatomy of the nervous system, and it's very much a puzzle. You really have to figure out where the problem is coming from. And I found it fascinating that people would come up to you with any kind of symptoms. It's not, people could have weakness, numbness, balance problems, visual problems, abnormal sensation. There's all kinds of symptoms that somebody could have. So it was so diverse and interesting, and you have to take that information and try to figure out where in the nervous system the problem is. And there's a lot of hands-on, a lot of working through problems with patients and having long-term relationships with patients, and I enjoyed that.
Yeah. Well, it's great that you did it. We need you, and thanks for being here for us.
Thank you.
It is easy to get clinical about a disease or injury and focus on the technology of the treatments, but to completely treat a patient, we need to work to understand how they see their world as it is affected by the disease. Kevin Boekoff has Parkinson's disease. One of the ways he's coping is by writing a book of short essays about his life and how Parkinson's has changed it. Here's one of those essays.
I forgot that I remembered. No ignition regarding my cognition occurred the other day. I forgot that I remembered. I usually take preemptive steps to intercept times of memory issues. For example, every Tuesday I bring the devotional at my church's men's prayer breakfast. The night before I make sure I have the message tucked in my Bible on the text verses page, thereby avoiding the problem of not remembering where said verse is in the Bible and not having to depend on the table of contents, or even remembering that there is a table of contents on a bad day, especially in front of people. I then put my Bible in a conspicuous place so that its presence reminds me that it's to go with me. Each day is unpredictable, so I cannot plan tomorrow's events. Just prepare for possible difficulties. But this is not a normal sometimers occurrence, but a seriously disconcerting event. However, this Tuesday, despite my strategy, I forgot that it was Tuesday. I ate my breakfast at home, and despite my Novocaine brain, went for my morning walk. When I got several blocks away, a serious no-nonsense rain began. As I trudged back home, and I had no more energy than to trudge, I came across a garbage man, one that I had had run-ins with on previous Tuesdays. He doesn't like pedestrians to get in his way. Thus, I remembered that I had forgotten where I should be at that very moment, at the restaurant, for men's breakfast. And I am the leader of said breakfast. So I began to plod along at a faster pace toward home. Once there, I grabbed my Bible, forgetting my lunch and mug of Bengal spice tea. I climbed into my 92 Sonoma and headed out. I arrived a little early for work. While sitting there waiting for the business to open, I noticed my Bible on the other seat. Guess what? I had forgotten that I remembered the men's breakfast. Now it was impossible to get there before everyone else had gone. Arrgh. I had forgotten what I should have remembered what I had forgotten, and then forgot that I remembered. I figured I better write this down before I forgot. Hey, I remembered.
Well, that's an interesting story. I mean, he was talking about remembering that he forgot. There's a lot of issues about memory that we should really talk about. What is memory? I mean, why does the brain do this? I mean, can you tell me the physiology of why a brain remembers anything?
Well, it's actually quite complex, and the brain has certain regions that course throughout the brain, networks that compose of memory circuitry. And so there's a lot of backup wiring so that you don't have a problem with that. But with certain conditions, there is degeneration of these regions of the brain. And so you can have difficulty with memory. A lot of times that happens with dementias, but also with people with seizure disorders or epilepsy, where they have some memory difficulties over time. But the most common one, or the one that we think of the most, is dementia. I think it's really hard for patients in seeing this last segment, the unpredictable nature of neurologic disease. it's really a challenge for people to deal with the day-to-day changes and not knowing what to expect. And I think that's a real challenge for people.
Well, I think about the things that people fear the most. I mean, I do.
Yeah.
Is the loss of the ability to know what's going on.
Yeah, well, it's lack of control.
Yeah.
People like, especially neurologists, are like this
Yeah.
too. We like to have
to
structure and to know what the plan is and to have an understanding of what to expect. And when you have a neurologic disorder, that gets really removed from you. So you have that sense of lack of control.
Let's talk about memory a little bit. There are, for example, antegrade memory is learning a new thing.
Mm-hmm.
Then there's the past.
Mm-hmm.
Let's go through those. Retrograde.
Retrograde is, yeah, forgetting things in the past, and antegrade
is the forward.
Right.
So, and the point is that you lose the antegrade first.
Mm-hmm.
And people who have Alzheimer's disease in particular will maybe hold on to all of that retrograde stuff, but
Right.
can't learn a new thing.
That's right. That's right.
Yeah.
Or, it's really their short-term memory that becomes most impaired. And when you talk to these patients, it's actually fascinating. They can tell you details about their past
Yeah.
and things that have happened to them, but yet if you ask them what they had for breakfast that day, or something they have to do, or an appointment time or something to that effect, they forget, or they repeatedly ask you the same question.
There was a great case that was presented at Emory when I was there. I remember this as a noon rounds. This guy was describing that you have to have this circle of neurons that kind of go like this around the brain, and if you interrupt that particular circle, and I can't remember the name of it, that you can't learn the new thing. Now, this guy had memorized all these wonderful things in the Masonic Lodge. He could recite Masonic Lodge rituals that are chapters and chapters of stuff, but he couldn't remember a new thing. And he did it by writing things down and then reading it and then reading it and then moving forward with his life.
It's very frustrating.
Very frustrating. So the question that I hear, and I wrestle with a lot with older patients, because I take care of a lot of older people, is how much of memory loss is normal? Yeah. I mean, we all don't remember names quite like we used to remember. How much of that's normal?
Well, it is normal to have some memory difficulty. I hear this all the time. I have patients that come in worried that they're having this early beginnings of a dementia, but really it's normal memory difficulty. And there's something called the aging process. There's a normal aging process. And we see it in the brain. There are changes that occur in the brain. There's loss of brain tissue that occurs normally as you age. And there's also a memory change that occurs. And so forgetfulness, like forgetting someone's name or phone number, or walking into a room and saying, "What did I come in here for?" I mean, that happens to everybody.
You know, that old joke that as you get older, you think about the hereafter more. You get up and go to the kitchen, and you get there and you go, "Well, was I hereafter?" Old bad joke, sorry. But the point is that that's normal. I mean, some people have theorized that as you get older, you dump all that unimportant stuff. You go, "I don't need to remember that. I don't need to remember that." I mean, you do that subconsciously. Yeah. Whereas when you're young, you try to hold on to everything because you don't know what's important.
Well, this stuff can happen from just being distracted or stressed, or it doesn't necessarily have to be that there is a memory problem going on there. It could be a medication side effect.
I thought of that when you were running through the seizure disorders. People who have seizure disorders, they're also on seizure medicines. Well, unfortunately, seizure medicines can cause memory loss.
Absolutely.
Any tranquilizer, the benzodiazepines, the sleeping pills can cause memory loss, and the antihistamines, the Benadryl.
They cause sedating side effects, memory difficulties. These are all things that can mimic some cognitive difficulty.
Yeah.
So,
So we have to accept the fact that that's part of the aging process.
Yes, and it is normal to have some memory difficulties. So what we're talking about when it comes to dementia is more than what we would expect for a mild cognitive impairment or a normal aging.
That was one of the other things that I wanted to ask you, is that how do you measure the memory? Now, I know that the mini mental status is a common test. Explain that to me.
Well, that is a very quick test that seems pretty silly, but when you look at it, it's actually a very useful test because it's easy to do. We do it right in the office. It's very quick. It addresses different domains of cognition, and it's a series of questions that add up to about 30 points, and you can, based on how somebody answers the questions, they lose points for not being able to remember something, or there's a calculation portion where you have to do a certain calculation or spell a word backward or something like that. And so they will lose points based on that. And so you can gauge a general idea if somebody has a cognitive disorder that's more than what you would expect for their age.
And I've heard also that really, if you look at all of it, it's that antegrade memory part of that test that's really probably the most important. One particular reviewer said it's the antegrade memory test, remember 3 things, and then come back and ask those 3 things again, and function. If they're the Tupperware in the oven, or if there is something that's just not functioning.
On there's also visual spatial function. You're asked to copy a figure, and that's something that entails you have to have an intact visual spatial function. So
that's part of it too.
Yeah, that's part of it too, absolutely.
Right. We met Kevin Boekoff at the beginning of the show. He sat down with us earlier this summer and talked about Parkinson's and how his writing has helped him cope.
I was diagnosed about 3 years ago, but about 11 years ago or so, I started having, just feeling really stiff and sore, like you worked out too much, and it was getting frustrating, and then it was years trying to find a diagnosis. Fatigue was really bad, and I ended up going to Mayo Clinic, and there's one story in there about one test that was testing for peripheral neuropathy. And it's a sweat test, so you're baked in an oven at 110 degrees for an hour. And so I called it condensation, not perspiration, And did not receive a diagnosis at that time, but a few months later, a tremor started. And so I brought it up with my neurologist in Sioux Falls, and we tried Mirapex, which is a Parkinson medication. And it was like clockwork when it would kick in. It was just felt like stretch and just relaxed, and the fatigue went away and felt really well. And then it would only last so long. So that was how he determined that it was a Parkinsonism. I feel better when I write because this is a fun type of writing, rewriting, and it also fits in my day, which I can feel good and I can feel bad and have to sleep, and you have good days, bad days, but it might be just part of a day. It's hard to predict. And so writing kind of fits in that. I feel good. If I wake up at 3 in the morning and I'm awake and sit down and write for a while and write and rewrite, and so there's no real pressure to have something done on a timetable like a job. It was my way of dealing with Parkinson's, helping work through the different aspects of it. And I turned in some of the stories to the National Parkinson Foundation newsletter in Sioux Falls, and they liked them and asked if I wanted a column in there. So I have the column Wanderings Through My Ponderings for the newsletter, and that was started in December of 2010. And in talking with the editor at that time, I said, I think I have enough to put a book together. So she encouraged me to do so. And so this was the culmination of that idea. And so the stories generally make people laugh, cry, things like this is the response that I've had. And that it's an eye-opener for people to see what it's like to deal with a chronic illness.
Thank you for that, Kevin. Please call in your questions about anything involving the nervous system. Call 1-888-376-6225. And you can also email them to questions@oncalltelevision.com. So let's talk about Parkinson's disease as he addressed it. You know, there's a lot about a condition called Lewy body disease. And some separate that from Parkinson's disease, some put it together. I'm confused on that. Could you straighten me out on it? What is Lewy body disease? Or Lewy body dementia?
Okay, well there's Parkinson's disease, and Parkinson's disease consists of a series of symptoms where people get tremors and bradykinesia, and bradykinesia is slowness of movement.
Right.
So people get very stiff and rigid and have trouble walking and so forth. So that's predominantly due to having less dopamine in your system. And so the treatments are focused on giving more dopamine.
Yeah.
And then there are other conditions that are what we call Parkinsonism, or sometimes they're called Parkinson plus syndrome. And so Lewy body disease is a condition that entails some Parkinson traits, but then also has symptoms of dementia as well. And there are a number of other types of Parkinson plus syndromes. So they're not true Parkinson's, but they have Parkinson-like symptoms.
Right.
And so some of them respond to the same medications, but some don't. And they're, both of them are neurodegenerative conditions, but the Parkinsonism tends to be a little bit more difficult to treat.
Right. Now, I see people who get Parkinson's disease or get early Alzheimer's disease or get any of these degenerative diseases commonly get depression. And they'll say, I am depressed. And part of it, I think, is I would be depressed too. I mean, this is a significant illness, and it's sad to feel that you're losing some ground. But is there also intrinsic with the loss of that nerve function by itself, not just being sad because I got this illness, but this illness causes sadness?
That's a really interesting question, because it is thought that there is depression in association with these conditions. It's clearly a higher percentage seen more so in patients with neurodegenerative disorders. There are people that don't have a tendency to depression. They may have difficulty dealing with the diagnosis or adjusting to it, but that's different than a depression.
That's a situational depression, which is real. We all have. We have all these adjustments.
Yes,
so
you do.
There was another question. Here's a question from Brookings. Can Effexor cause memory loss? So I just made a fuss about lots of drugs that can cause memory loss, particularly, and I have a problem with the benzos, most of the sleeping medicines, you know, the not trazodone, but almost all of the other sleeping medicines are benzos. And I believe they've been shown to significantly, just like Valium, their parent drug, can cause depression. What about Effexor? Can cause memory loss? So this question is, can Effexor cause memory loss, or can Prozac cause memory loss, or can any of the antidepressant group, not the Valium tranquilizer group, but any of the antidepressant group, cause memory loss?
Patients on these medications can have memory difficulty, and frequently it's hard to decipher if that's part of their underlying illness or not too, or if they're on other medications, or is it from another side effect like somnolence. And so what we tend to do in general with medications, if you're suspecting that there's a side effect, is trying to change them to a different one, or switching the dose a little bit, or sometimes looking for other things. Are they having trouble with sleep? Maybe their sleep deprivation is causing memory difficulty and so forth. So looking for other causes of it.
That's a real big area we could go into, but I think that I personally have read some data that suggests, doesn't prove it, but that looked at in rats and it looked in humans, that the citalopram specifically, but other of that SSRI antidepressant groups protected against progression of dementia. And of course, that was very encouraging to me to push in the direction of using those medications when I'm kind of conservative with medications, and I really like to encourage people, instead of using pills, let's get you exercising, because exercise is a huge help for depression, but also for everything,
Yes,
and for memory,
well,
and for memory.
Brain health.
Brain
health. It's good for reduction of dementia, actually, because as you're exercising, as you're improving blood flow, you're improving blood flow to your brain, more oxygen to your brain, your brain is healthier, happier, there's more nerve cells preserved. So it's just good for all neurodegenerative conditions.
Right. And may clean out those proteins that are collecting in certain spots in your brain, causing those memory loss. Well, back to the issue of antidepressants used to prevent dementia. I brought this up at a national meeting, and of course the neurologist from Hopkins, I think, some very prestigious neurologist said, nope, not yet, not data. So, but maybe it's coming.
Well, yeah, we're not using it routinely for treatment of that, but
for dementia alone.
Right.
But certainly, if there's a little bit of depression, I'm quick to add it. What do you recommend for post-herpetic neuralgia after shingles?
Oh, okay.
Good question.
Well, that is actually a very painful condition. That's neuropathic pain, which is something that responds to these neuropathic pain medications, which are frequently anti-epileptic or anti-seizure medications.
Yeah, anti-seizure drugs for these neuroleptic
which sounds kind of strange, but if you think about it, what's happening is those pain nerve cells are overstimulated. They're discharging abnormal pain stimuli, and so these anti-seizure drugs are inhibitory, so they quiet them down. And so gabapentin is commonly used, Tegretol, Lyrica, those are the most common ones.
Okay. Alzheimer's. It is a dreaded diagnosis, and it portends a deterioration of the quality of life for the victim as well as their family. But how you view your situation can blunt that effect and maintain the dignity we all have.
When Ellen McVay started having trouble with her memory, she thought it was just a part of getting older. Her doctor told her it was Alzheimer's.
I felt like I was a young woman still, and so I was just shocked that I was given this diagnosis.
Ellen's husband, Dr. Michael McVay, was equally surprised. And being a recent retired cardiologist, his medical mind couldn't accept it.
It just blew me away. I wasn't expecting this at all. It just caught me totally by surprise.
The news hit the McVays hard, Ellen especially. She says she couldn't eat and cried every single day. But after 2 years of depression, the social worker in her was rekindled. She chose to be happy and not let this disease define her.
It was lovingly aggressive for me to reactivate who Ellen really is. And I am Ellen, and I happen to have a wounded brain.
Ellen says her husband has been her strongest supporter every single day. He says his biggest struggle is trying not to help out too much and let Ellen work things out on her own.
Like heart disease, like cancer, there's a daily reminder. So it's a matter of trying to accept that and to not push it away and to deal with it the best we can.
Alzheimer's disease is the 6th leading cause of death in the United States, with 5.4 million Americans living with the disease. 200,000 of those are like Ellen, having been diagnosed with early onset Alzheimer's.
So Alzheimer's is no longer a disease of old people. This is our parents, our siblings, our spouses, our brothers and sisters. The baby boomer generation is really facing this disease right now.
The biggest challenges are funding for research and lack of participation in clinical trials. something the Alzheimer's Association is working to correct through the Walk to End Alzheimer's and other fundraisers. The McVays are also advocates for the expanded research by being on the state Alzheimer's board. Michael knows the power of research funding, as he saw it firsthand in his career.
And I saw what funding did for research in cardiovascular disease. You know, we have just made such huge inroads. And we're taking baby steps in Alzheimer's disease right now, and we really need to put a fire underneath it.
Right now, there is no cure for Alzheimer's disease. The McVays stay grounded and optimistic about what the future may hold for Ellen and others suffering from Alzheimer's disease. But Ellen says until that day comes, she will continue to rely on her faith and, of course, her best friend.
I choose to be happy. I choose to pay attention to what my thoughts are telling me, and that's where the centering prayer has been such a gift, because I can notice that my thoughts can be wild and sad and, oh my God, why did this happen to me? Or I can let go of those thoughts and just be glad that I am alive today.
With your Avera Medical Minute, I'm Jake Iverson, KSFY News.
When I called Mike McVay, because I heard that Ellen had done something like this, he said, you know, take that medical minute and use that. That'd be great. And thank you, KSFY and the Medical Minute and the McVays. One of our callers asked to differentiate between dementia and Alzheimer's disease. How would you do that, Lisa?
Well, dementia is a very large umbrella of different types of neurodegenerative cognitive disorders. And so
cognitive meaning thinking.
Yes, memory, thinking, ability to thought process. And Alzheimer's disease is a type of dementia. So dementia is the general term for these many subtypes. So Alzheimer's is one type that people know quite often. But there's other types. There's you can have what we call multi-infarct, which is from having a lot of different strokes. You can have a Parkinson's disease dementia, a frontotemporal dementia. There's multiple different types, but
50–60% of the demented people have what we presume is Alzheimer's disease.
The most common is Alzheimer's and vascular dementias are very common.
Right. And you said frontotemporal. Mm-hmm. That's one that people won't ask that question, but it's kind of interesting.
Yeah.
What is that? Tell me.
Well, that's a dementia that is focused on the, well, we're going to have to turn to the model for this one, Rick.
Go ahead.
Let's take out our brain here.
All right.
And this is obviously a model of the brain. This is the cerebrum, the cerebellum, and then the brain stem down here. And so
show that again.
This is the cerebrum. This is the cerebellum. And the cerebellum is for balance and coordination. And then this is the brainstem, which turns down into the spinal cord going down the back. So the cerebrum has different lobes. There's the frontal lobe, parietal, temporal lobe here, and the occipital lobe. And so in a frontotemporal dementia, that is a dementia where there's degeneration of certain portions of the brain, and it's mainly the frontal and temporal regions. So patients will have symptoms that reflect that area. They'll have difficulty with their memory, but they'll also have, in the frontal regions, is a lot of personality type of symptoms. So people will have changes in their personality. They'll become very disinhibited, inappropriate behavior sometimes. A lot of psychiatric symptoms can develop over time, like depression, anxiety, mood changes, mood instability. So it is quite a struggle for people that develop that. And then speech difficulties too, from the temporal lobe.
Yeah. Part has a speech. Well, that's fascinating. I love that. I love our model.
Yes.
Yes. Thank you. Joni's the one who decided we were going to do that, my wife, Joni. Primary aggressive aphasia. What is it and what will help?
Well, that is another type of dementia where it is very specifically involving a portion of the temporal lobe. Aphasia is is a word to describe difficulty with expressing your speech.
Not aphasia or dysphagia, which is swallowing. It's
right.
phasia, which is speech.
Right, so difficulty with your speech. And so people have difficulty specifically with their speech and reduced verbal output over time. And that is something that is a progressive process. So people will start noticing symptoms like word finding difficulties. They can't find the right word for something, or they know what they want to say but they can't get the word out. It will become more and more difficult for them over time, and these are symptoms that progressively worsen. And it is something that is not a reversible condition. It's a type of a dementia.
Okay. We talked about medications causing memory loss, and this caller from Ipswich said cholesterol-lowering medicine, cramps in the toes, and forgetfulness. Are they related to the lipid-lowering drugs? I know that statins have that reputation. I've seen it. Have you seen that statin-induced memory loss?
You know, what I tend to do is if somebody's coming in with memory difficulties, I tend to just run through their medication list and see if they're on something that obviously can cause that. Then we talk about those medications, like the seizure meds and the real common ones that we spoke about.
Beta blockers.
But then,
sometimes do
yeah,
that.
and what I tend to do is just go through, and what we'll do is look it up and decide, is this reported to occur? Because even if something, and I'm sure you see this all the time because I do too, if something, a patient can tell you that they're experiencing something from a medication, and it may not be a common side effect, but they're experiencing it.
Right.
And you know, it's just because it's not a common side effect doesn't mean it's not happening to them. So,
I'll go through that list and cut as many as I can cut. I mean, just blast away if I can, and then start back if they need those medicines, add them back slowly and one at a time and see if...
I think that happens a lot, that over time people tend to get more and more medications added onto the pile, and especially with primary care, you really need to reassess that list and kind of get rid of the old stuff, do the garage sale.
2 questions about Alzheimer's really quickly. Alzheimer's inherited, yes or no?
Yes and no.
But mostly not.
Mostly not.
Okay.
There are some variants that can be inherited. It's a typically the younger age Alzheimer's, but usually it's not most of the time.
15 seconds, lifestyle recommendation. We talked about exercise, that's the big one.
Exercise, yes, and diet, and stop smoking. People need to stop smoking. This is, you know, reducing blood flow to your brain.
There it is.
That's what it does.
First thing to do if you're having memory loss, quit smoking.
Yes.
When there is an injury to the brain, one can suffer a variety of problems. Some may be temporary or can be improved with therapy. Some may last the rest of your life, and sometimes it may be years before an impairment comes to the surface to change your life.
I was one of those guys who, when you ask him to do something, he's probably going to do twice that. And that's who I was. And then came the ugly day. We were out in the middle of, what county is that? Millette County. And in the middle of nowhere. I mean, the middle of nowhere. Your cell phone wouldn't even work. And I had shot a turkey the day before, and we didn't get it. I shot it with a bow and arrow. And I thought, well, you know, I'm going to take another look for that turkey that I shot yesterday, because usually, you know, when you hit them with a bow, you don't kill them outright. I walked down into one sort of a bottom, and that's all I remember. That was it. That's where he shot me. The blast hit me right in the face, I mean, right there. And it wasn't much bleeding because it was so hot going in that it cauterized everything. One went through my eye here, one went through my eye over here, and but there's still probably 40 or so right in here. and went to general, or PT, McKinnon, and I was there for 3 months. And when I left, I came home and everything was going to be fine. I actually had I could use my right hand and right leg and right side of my face and all that. And, you know, I was fixed. I was cured. It's 6 years since the surgery, or since I went in the hospital. And at that point, at about 4 years, I started not remembering things, and I started not using this right hand, and my right leg really hurt me. Then it just went from there to this. And I think probably the biggest thing that I had to learn to do was to ask for help. And I'll tell you what, that was the most difficult part of this whole thing. My memory is so short that I can hear somebody say something really important, like a church sermon, and I walk out of church and I can't remember it. Not being able to do what you wanted to do, and not being able to say what you wanted to say, and not thinking that things were important like they were, and all those things wrapped up into one, and I didn't want to do it anymore. But I finally, and this happened 2 or 3 times in the last 6, 7 years, there are things which you can do even though you've had a brain problem, that if you go and try them, you'll find out you can do them. And that's important. Getting on that jet ski was a major task. I mean, I almost drowned getting on the thing. And, but once I was on it, I was fine. Took my wife around the lake and dropped her off and did some daring things. I don't know that getting on a jet ski is all that important in life, but for me it was.
That's so good.
That's
That's
great.
really great.
That's cool.
I
want to get on a jet ski now.
Yeah. You haven't been on a jet ski?
I've never been on a jet ski.
Oh, that and snow.
Have you?
I have. And snowmobiling in the Black Hills in the winter. Those two things are very much alike, and oh, what a joy.
That's 2013.
There we go. Do
Bucket
that.
list.
Try that. But be careful. That's the major
I'll wear a
key.
helmet.
Wear a helmet. Yeah. Here's a question from Madison about Huntington's disease. Explain it.
Huntington's disease is a type of dementia that's an inherited condition, and it's a dominant inheritance. It is
dominant meaning
that if you carry the gene, then you will have the condition. And so, unfortunately, there's not a treatment for stopping it. It is a condition that can affect younger age people as well. And so what happens is you get dementia, so memory difficulty, but you also develop abnormal movements where your coordination is very poor and imbalanced. And so it becomes, there's a lot of depression associated with that condition as well. So.
And it's sort of like you'll get it or you won't. I mean, who is the famous, the famous folk singer? Jay, what's the famous folk singer that
had Huntington's?
Had Huntington's.
I didn't know that.
Not Kenny Rogers. Is that Kenny Rogers? No, it was, no, it's another one. Right. But at any rate.
That'd be interesting to know.
Yeah, Arlo Guthrie, that's it.
Okay.
Arlo Guthrie. His father had it, Woody Guthrie, and then Arlo doesn't have it, which is a blessing.
Yeah, there's a lot of controversy in terms of testing, because once a family member has it, their children, should they be tested or not?
Oh, and will they ever get insurance?
Yes, that's another problem. But I think I've worked through this with families. It's a real struggle because it's a real ethical dilemma, because to prepare for family planning and to decide, you know, on having their kids and
I guess, you know, and my thought is that adoption is a wonderful thing. I mean, it's the same. Those kids are yours. And so if there's a fear or a concern, I would just say adopt.
Consider your options.
Consider adoption. It's a wonderful thing. Here's a question from Sioux Falls about transverse myelitis. What is transverse myelitis?
Transverse myelitis
Where in our anatomy?
Okay, well, what we're talking about is myelitis, which is the spinal cord. So it's itis is inflammatory. So if you add itis to anything, it means inflammation of. So myelitis is inflammation of the spinal cord. So transverse myelitis is something that can occur in isolation on its own, or it can occur with certain neurologic disorders, the most common of which we think about is multiple sclerosis. So multiple sclerosis is an autoimmune type of neurologic condition that affects the brain and the spinal cord.
Your body is turning against yourself, and antibodies.
Well, it's actually fascinating. The immune system is the system in your body that's there to fight infection and protect your body. But there's some abnormal communication. Something abnormal happens, and your immune system abnormally recognizes something in your body as a foreign substance, so attacks it. And so the condition will vary depending on what's being attacked. Certain types of arthritis can occur, or there's all different types of autoimmune conditions. MS is one of the types of autoimmune conditions.
Right, and by definition, it's not a degenerative disease, but it really is. I mean, it causes degenerative process.
It is. The major thing that is attacked is myelin, which is the coating on the nerves.
The insulation around the nerves.
Insulator that allows the nerve signal to travel quickly. And so that gets kind of stripped or attacked. But there can be axon loss. Axon is the actual nerve itself. So you can have loss of nerve cells over time. So there is a degenerative component.
But the thing about MS is it's multiple spots in the central nervous system over multiple periods of time, and it's not predictable. Sometimes it happens and then it doesn't happen again.
Right.
Here's a caller who said, I just been told that I'm 65. Again, different stories. When does it typically occur? Typically, it's a younger woman. Yeah, but it can occur anytime.
It can occur at any time. We're finding that there are two ranges of most common, so between 20 and 30, and then there's another increased incidence between 40 and 50 around there.
But it can occur anytime.
It can occur at any time. I have patients that I've diagnosed in their 70s.
All right, quickly, caller asked about Alzheimer's therapy. You know, we did address considering the idea of SSRI antidepressants. There are other medicines for Alzheimer's disease.
Well, the medications that we use for Alzheimer's are basically the first-line medications are ones that work on Aricept, like medications, and those are ones that work on acetylcholine. They try to increase the acetylcholine, right?
And then the other, quickly.
The Namenda, which is something, it's actually a different mechanism of how it works, but that's something that we use usually in more moderate to severe Alzheimer's disease, but we add it in, we use both medications together, and more data is coming out to show that the Namenda or memantine can be used earlier on as well, so we're seeing benefit with that.
All right. Dementia is at once a huge diagnostic and therapeutic challenge for any physician, and a terribly devastating and dreaded condition for any patient and family. Something like 6.8 million people in the U.S. have dementia, and almost 1/2 of all people greater than 85 years of age have the diagnosis. Take hope, however, since that means almost 1/2 of those greater than 85 are not demented. This is not a simple topic. Dementia is not a specific disease, but rather a term for a number of symptoms that can be caused by a number of brain disorders. The National Institute of Neurologic Disorders and Stroke defines people with dementia as having impaired intellectual functioning that interferes with normal activities and relationships. The cardinal sign for dementia is the loss of antegrade memory, or rather losing the ability to learn a new thing and to hang on to it. A simple test for antegrade memory is to ask the patient to remember 3 objects and then ask later to recall those 3 things. Sometimes people with significant dementia can remember much of their past, but they cannot learn a new thing. Memory testing is not all of what defines dementia, however, since intellect involves other faculties such as language, perception, reasoning, judgment, and behavior. Learning, or antegrade memory, pulls these other brain activities together, however, and therefore, I think, is the crucial element for brain function. More than 60% of all dementias are caused by Alzheimer's disease and are characterized by a gradual antegrade memory loss, preservation of a gait, subtle personality change, and a steady general deterioration over time. About 20% of dementias are called vascular dementia and are caused by small and large strokes. These generally happen quite abruptly. They affect the gait, they preserve personality, and may or may not progress over time. Some other causes of dementia include Lewy body dementia, which acts like or is associated with Parkinson's disease, frontotemporal dementia, which can cause huge personality changes, and chronic traumatic encephalopathy, which follows repeated severe head trauma in boxers, football players, soldiers. The differential diagnosis also includes memory loss from thyroid and B12 deficiency, brain tumors, and depression. It is my sincere hope that you, the listener, can continue to learn a new thing. You know, we've got some other questions, though, but I want to pour through them. We've got just a few minutes. Is there a role for vitamin D in MS?
Yes, vitamin D replacement is very important in MS.
Okay. How will migraines affect your brain?
Migraines, well, when you take a picture of the brain in somebody with migraines, usually it's normal. Sometimes you see small little white spots in there, but typically you won't see any abnormal findings in there.
Quickly, brain trauma, repeated brain trauma, soldiers are coming back, brain trauma, memory loss, comments?
That is usually because there's disruption of the nerve cells. There are various layers of nerve cells throughout the brain, and those connections between the layers get disrupted when you have head trauma. When you hit your head, your brain is sitting in spinal fluid and moves forward, hits the inner tablet of the skull, and this kind of rustles the brain and causes some disruption of those networks.
We've got tons of questions.
This brings to answer them quick, but it's hard.
Thank you. This brings a close to our show on neurologic disorders. I sincerely thank our studio guest, Dr. Lisa Viola, a neurologist practicing with Neurology Associates in Sioux Falls, for helping answer all of your important questions about illnesses that encompass the nervous system. Thank you very much,
Thanks.
Lisa. 9 confirmed cases of influenza have already been reported in South Dakota. 4 were in children less than 4 years of age. 2 adult cases were severe enough for hospitalization. This year's influenza vaccine is already available. It's not too early to get your flu shot, and it's effective for 12 months. Don't wait until Thanksgiving. There are 2 new components in the flu vaccine this year, so it's different than the vaccine received the last 3 years. There is no vaccine shortage this year. Earlier this week, I got my shot. It doesn't really hurt too much. It's easy, and it's much better than spending time dealing with getting the flu. Although we can't predict the severity and timing of this year's influenza outbreak, We do know that there will be influenza circulating, and it's already started, so please get immunized soon. Next week, we have a special on-call addressing Obamacare, or the Patient Protection and Affordable Care Act. We will have a live audience, and our panel of medical experts will take your call in or email questions, or join us at the Methodist Community Life Center across from Mr. Movies in Brookings at 7 p.m. next Thursday night. Join us. Michael Fox, who suffers from Parkinson's disease, tells us, one's dignity may be assaulted, vandalized, and cruelly mocked, but cannot be taken away unless it is surrendered. Until next time.
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call, starting its 11th year of opening doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, Regional Health, the Brookings Health System, Dr. Mark Bubock with Dakota Allergy and Asthma, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.